the topic today, the utility of maps for infection control and disease surveillance. Stephen?
Yes, hello. So can you guys hear me?
Yes.
All right, awesome. So my name is Stephen Furmanek. As Dr. Ramirez said, I have been working with either Dr. Ramirez, Dr. Carrico, and with infectious diseases for about 6 years now. And so today we're going to talk about how maps can be used in infection control, disease surveillance, and epidemiology. So lots of good things. So there's actually a pretty long history of using maps for epidemiology. In fact, the modern epidemiology was more or less kickstarted by a map, and we'll get to that in a second. But thanks to the pandemic that's going on, there's been a lot more renewed interest in using maps and spatial analysis for infection control and for disease surveillance. I'm sure at the beginning of the pandemic, many of us went to the Johns Hopkins coronavirus tracker that had the map of the United States and how many cases were showing up. And that was actually being used with, it's called geographic information systems. It's a type of software you can use for creating maps. And so to talk a bit about the history of maps, one of the things that we need to sort of bring up was the previous epidemiological theory. So miasma theory was the idea that dying and decaying things could produce bad air, that then inhaling that bad air could cause disease. So the idea of germ theory, that specific pathogens or viruses, microbes, those sort of things caused infection, that wasn't really established yet. And so London had several cholera outbreaks in the early and mid 1800s, and this is largely due to inadequate sewer systems. And so they were dumping sewage into the river Thames. And then water companies serving these districts in London were drawing contaminated water. So now we know that from a public health perspective, clean water was one of the most effective public health interventions that has existed, but at the time that knowledge wasn't fully known. So in 1854, there was a cholera outbreak on Broad Street, and this is in the Soho district of London. There were about 600 deaths in total due to this outbreak. And so one early sort of prototype epidemiologist, Jon Snow, not to be confused with Game of Thrones Jon Snow, was an early supporter of germ theory. And so 1854 is actually when the microbe that causes cholera was first discovered, but it wasn't really fully accepted then. So John didn't like miasma theory and thought, well, maybe if we create a map and try to identify a source of contamination, then we can figure out what's going on. So that's what Jon Snow did. So this is actually a sort of zoomed in copy of his map. So it actually is quite a wider extent. And so these little bars here represent people who had cholera during the outbreak. And so this is per, address and unit. And so what he found interviewing people from the area was that a lot of people who were sick and dying were people who were using this water pump on Broad Street. And so this is actually a quote from one of his papers, that the result of the inquiry then was that there had been no particular outbreak or prevalence of cholera in this part of London, except among persons who were in the habit of drinking water from the above mentioned pump well. So eventually, the story famously goes that he took the handle off the pump so no one could use it. And so the outbreak was able to die down and subside. And eventually they replaced the water pump. And yes, unfortunately, it wasn't an immediate success in that many people were still skeptical of germ theory. And they didn't want to admit that by drinking water contaminated with sewage, that was a hard reality for people to accept. Nowadays, the fecal oral transmission of disease is pretty well documented and understood, but it was much more controversial in the mid 1800s. And actually, John Snow died only a few years later. So he's a very interesting figure in the early field of epidemiology. And so this type of mapping is actually still used today for outbreak infections. So here we have in the early 2000s for the first SARS outbreak. Here's an example where some researchers were looking at an outbreak in a Hong Kong high-rise where they theorized that the flow of air was potentially causing the outbreak. It's a little bit difficult to see, but there's 99 cases. So this was the sort of epicenter of the outbreak of SARS in this high-rise. And then we have 20 cases in this building, 25 cases in this building, 20 cases in this building, but then only 4, 7, and 6 cases of SARS. So what they theorized is that because of the direction of wind, which is kind of shown in this figure here, that there was SARS being carried airborne to other buildings to try as one sort of explanation of this. And, you know, there's several examples, especially with the COVID pandemic now, of renewed interest in terms of how is COVID being transmitted and sort of looking at where cases were happening, and was it droplet infections, were it airborne, sort of the roots of disease. So in using maps for your own facility this way, you know, you could look to identify not just COVID infections, but really any hospital-associated infection that way, or healthcare-associated infection. So there's rising interest in this level due to the pandemic. It may be very realistic to think that as new hospitals are built or hospitals are remodeled, engineering teams will have questions for infection preventionists about airflow and things of that nature in terms of making sure that we aren't creating or designing systems where diseases could be spread in that manner. Another example of this would be like sick building syndrome, the Legionella outbreak originally, where at the Legionnaires Conference. So there's many instances where these sort of tools can be used for individual infection prevention. So we're going to take a second to pivot though, because there's all sorts of things that you can do for maps. And so specifically what I wanted to talk about a little bit more today in detail was maps that are used for disease surveillance or just other general geospatial epidemiology. And so on a larger scale, you can display data on population health or disease incidence for a larger area, a more community-based model. So you can think of it that as either the county level, the state level, the country level. You could go sub-county level if you wanted to look at various smaller units of geography. And so we're going to discuss two kinds of maps today involving this. So the first kind we are going to discuss are Choropleth maps, and then we're going to talk about kernel density heat maps. So the important thing to know for a Choropleth map is what geographic unit you're using. So what a Choropleth map does is it's going to display a distribution of data using either a color gradient or a shape gradient, where it's going to have the colors change based on the values of your data, or the shape size change based on the values of your data. So these maps here, these are two maps of Louisville, and we have subdivided Louisville into zip code tabulation areas and census tracts. So thanks to the Louisville city-county merger that happened about 20 years ago, Louisville has a very well-defined geographic area. And that also means that we can do incidence studies in Louisville for disease that are well-defined because we have good boundaries. So census tracts are what happens when you split counties into smaller units. And so these are designed with the census in mind in gathering data on demographics or housing or any sort of area in that regard. So as you can see, census tracts actually kind of model roads. So if you're familiar with the geography of Louisville at all, this right here is 264. And then this outer loop right here is 265. And then we have the major roads that go out of town that also show up. And then we have 265 runs along down, or not 265, 65, excuse me, runs along here. So census tracts are split mostly by roads to try and divvy up the county into chunks that are usable and meaningful for using research. Zip codes were originally created by the Postal Service to make mail delivery more efficient back in the 60s. And so zip code tabulation areas are what the census uses to sort of approximate the boundaries of zip codes. Now, zip codes actually, most of the zip codes along the border of Jefferson County actually extend outside Jefferson County. So that means that if you have data that's in a zip code tabulation area or just zip code level data, then that may include people who are outside your geographic unit of interest. So that's the downside for using zip codes is largely that you may have people who are not accounted for. Like if you're looking at the denominator of Louisville, as the population of Louisville, in Louisville specifically being Jefferson County, then having patients who live outside of Jefferson County in your numerator is something that will lead to just incorrect estimation for your incidence because you have people in the numerator who aren't included in your denominator. So for example, if we have 5 people outside Louisville, then our incidence could potentially be off if it's especially a rare disease. So long story short, while zip codes are useful for many forms of data, for example, lots of large administrative databases have data at the zip code level and not at the census tract level, there are still lots of limitations with the data that you provide. And so eventually I just wanted to briefly talk about all of this to then introduce what we're going to do with our data here. So if we look at census tracts in Louisville, this is a histogram with an overlaid sort of density plot on it of the values of, and here I'm using percentage poverty. And I'm going to continue to use percentage poverty for a lot of these examples of Choropleth maps, but there's many things that you can use for this level of data. And so as you can see, it's a very skewed distribution. It's very much right skewed. There's outliers as we get above 40%. So what we're going to do then in a Choropleth map is we're going to cut up this distribution, and I'm going to drop the histogram here and just use the distribution line, but we're going to cut it up into segments and then give a color to any features that are in those segments. So for example, here we'll have the lightest yellow for where there's the lowest percentage poverty. Then we'll have, darker shades moving to sort of a maroonish red as we get higher. And so what that looks like then, if we were to plot this on a map, is it would look something like this. So now we are taking into account the geographic location of all of these census tracts. And so this is actually the same data. This is the percentage poverty per geographic unit. And I'm using the same scaling here. So for zip codes and census tracts, so you can see the slight differences that you get. And the big thing to note about census tracts versus zip codes, especially in Louisville, is that this census tract right here is where the airport is. And no one lives here, at least according to the census. So this is sort of a dead zone in the middle of the city. However, if you look at the zip code here, towards the top, it could almost look like you have a lot of people in poverty that live in the airport. So that's one downside of using zip codes as opposed to census tracts. And so that would be the difference there. Now, Choropleth maps then provide a powerful tool to visualize data for lots of different types of geographic units. So if you look at, you could use it at the county level, at the state level. There's lots you've probably seen Choropleth maps before, and most of them use color gradients. Some use graduated symbols, as I mentioned earlier, where the symbol size will change in proportion to the value. So previously we were using a sort of light color to dark color to go like low value to high value. So then they might use like small symbol to large symbol to do the same thing. And you can actually use symbols overlaid on top of colors if you want to compare two different variables on your geographic map that way. But you have to be careful because it can become difficult to read. Now, while Choropleth maps are a powerful tool to make a pop culture reference, with great power comes great responsibility. So I'm going to show you a couple maps, and which map makes poverty look worse in Louisville. If you were to totally disregard the legend down here, if you were to totally disregard the legend, then you would intrinsically say, oh, well, this one has darker color places, so the map on the right makes poverty look worse. But this is actually displaying the same level of data. It's just how we've cut the data up for the coloration has changed. So what we have on the left here is called equal interval breaks. So if you look at our legend, about every 15.3 to 15 it's actually 15.25, but with rounding, we are changing the color gradient. Whereas here we have quantile breaks. And what quantile breaks mean is that we're going to have 20% of the data, since we have 5 groups, 20% of the data is going to be in each color group, meaning that we should expect roughly the same amount of census tracts to be the same color. So there's lots of ways that you can do this. And so what I've done on this next slide is I have that same distribution of of poverty, but then I have essentially where the breaks are occurring. So in equal interval, as you can see, the lightest color here is taking up a great amount of the data, whereas we have more and more outliers in this color size. Whereas for quantile, you can see that the density here, the largest density has the thinnest area. So that's because it is if you think of a normal distribution within one standard deviation, 67% of your data is going to be found. So even though this is a skewed distribution, still we have a very thin area here to just get 20% of our data in this quantile. So the color gradient can be misleading. So it's always important to check the legend for what the color scaling means. And then whenever you have methodology for Choropleth maps, they should include what kind of breaks were used for displaying the data in that manner. And there's a few more algorithms that are pretty commonly used. So this is the natural breaks algorithm. And what it does is it looks for where there are clumps of data. So this actually works best if you have potentially a multimodal distribution where you have multiple peaks, because it will try to clump your data in that regard. So it looks rather similar to the quantile map, but there's less emphasis on the sort of extreme, that upper end. And then another really useful tool is if you look at plotting the distribution of data itself. So here we have a standard deviation as the color gradient. So the blues are less than the mean. So this sort of bluish purple, the light color here, is going to be essentially the less than the mean up to 1 standard deviation. And then this darker shade is going to be less than 2 standard deviations from the mean. And the reason we don't go as far further is because it's a very skewed data distribution. So there's actually, we stop at 0%, so we can't go further. And then the sort of pink to red is then our 0 to 1 standard deviation, 1 to 2 standard deviations, 2 to 3, and then greater than 3 standard deviations. So for a normal distribution, we expect 67% of our data to be either this light blue or this light sort of pink. So that covers almost every census tract that we have. And then as we get further along, you'll have 95% of your data is going to be within 2 standard deviations. And then 97 or 99.7% will be within 3 standard deviations. So if you are more than 3 standard deviations away from the mean, which is what these 5 census tracts are, then that represents, if you were to look at a mean distribution, a almost impossibly low chance of that happening by chance if there was no sort of correlation or relationship here. So the fact that there is a clustering here can tell you that, hey, there's something going on. Now, this is actually, if you are familiar with the geography of Louisville, the west end of town is colloquially considered to be more poor off, and actually Louisville is very clustered that way, in that poverty, if we go back to our poverty map, poverty is very much concentrated on the west end of town and slightly a little bit in this area as well. So Louisville is by some characteristics very very compartmentalized in the clusters that these have. So that's just a couple of the ways that you can use Choropleth maps for describing and analyzing the data that you have and looking at areas. So you can extend this to then disease incidence. So let's say that you had a specific disease, instead of poverty, let's say that this is where disease was, then you would know that, hey, we need to investigate these areas because the incidence is much higher than it should be under any normal process. So then when we talk about kernel density heat maps, we need to discuss what a kernel density estimation is in general. So as I mentioned earlier, we had the density plot of our data for poverty in Louisville. So what kernel density estimation does is it takes every single point and then it tries to fit a distribution over it. And then you get sort of it creates peaks and valleys based on that distribution. I'm not going to go into more detail than that because unfortunately it's a rather involved topic. But what you can think is that if we put lots of standard normal curves on the sort of where points lie on this distribution, we can then add up the heights of those curves, and that will give approximately this density figure. And the wider the distribution that we provide, then the sort of almost flatter the distribution will get. So for maps, imagine you're doing the same thing, but instead of one dimension, instead of being along this one variable, you're using it by latitude and longitude. And instead of using a standard deviation for a normal distribution, you're going to use a search area that could be defined, like say 1 mile or 2 miles. And so what it's going to do is it's going to say, here is a point, then is going to look for other points within that area and produce a sort of estimate based on nearby areas. So what that looks like would be something like this. So this is a kernel density heat map. And this is using a approximately 2 mile search area. And so remember, as I said, the search area that you're using can determine how sort of flat or spiky this looks, depending on the heat map. But what we can see is that within this color gradient, so in those areas that are the lightest color here, then that value would be the number of persons per square mile who would be having this disease. So in this case, this data actually comes from our adults hospitalized with pneumonia study. that we did is the U of L pneumonia study. So we published this in 2017 in Clinical Infectious Diseases, and this is a new map that was created for this presentation. But it's displaying essentially what are the incidents of CAP hospitalizations of Louisville residents. So in this, as I said, the lighter area, about 0 to 3 patients per square mile will be hospitalized with CAP within 1 year. When we get into the darkest areas, what that means is that within this area, almost 34 to 41 patients are going to be hospitalized per square mile per year. So you can see the incidence here is being plotted, but the zone of color corresponds to then what the incidence is. So as you can see, there is, at least from a spatial relationship, if you remember, poverty was very, very much overlapping in this area. Well, it turns out that it looks like pneumonia is as well. Now, there is one important consideration to make, which is that if we go back to a less complicated map, here we have a bunch of small census tracts, and then it gets wider. So you could make the argument that, is this not just a function of population density? So if we fast forward a little bit, here I have population density in persons per square mile plotted in addition to the persons hospitalized with CAP per square mile. So you can see that it does look like there could be some level of correlation between population density and persons with CAP. Now, because we're using that 2-mile range to search, if the population density is high, if there's no difference, like if everywhere in Louisville is equally likely to have CAP, then we would expect to see, to some extent, a similar relationship. So there are more tools that are needed in order to show that this area is at increased risk with a kernel density heat map. So this is actually from the figure in our CID article. So what you can use is there's a software called spatial scan, or SAT scan for short. And what it does is it looks at the geographic features that are there. It looks at the incidence and then compares it to features outside that area, and then says this area accounting for the underlying population is at increased risk. And so what we found was that for the patients within this sort of dashed zone, that you were 1.65 times more likely to be hospitalized due to CAP. So, and that's accounting for the underlying population there. So we can say with this statistic that it's not just a function of population density. There is more going on than just, people close together are showing up as having CAP. And so what we've done in the article is we have other sort of geographic features, Choropleth maps shown. So we look at race, we look at poverty, we look at the distribution of patients who are older adults, so those age 65 and higher. And so since race and poverty are very much correlated in Louisville, and they are also geographically clustered, then it would appear that there is I'm going to say a epidemiological and ecological association. So we can't necessarily state that everyone who is hospitalized in this area is going to be someone who is poor or someone who is African-American race, but there appears to be at least a geographic association with those. So what that can tell us is that we can prioritize these areas for interventions, specifically if we want to look at like pneumococcal pneumonia vaccination efforts or things of that nature. So that's what you can do with heat maps. There's lots of other utilities for these, but that's I'd like to still have time for questions. So I know we're almost running over on time. So does anyone have any questions? I know that I covered a lot of information in a pretty brief amount of time. So yeah.
Stephen, I appreciated that because, we're all thinking now about what is the impact of the care that we provide and what is happening in our community. And so we're kind of reframing our perspectives and beginning to look at, a lot of the notions about health equity and how, are we paying particular attention regarding health issues among individuals in the population, or as we develop interventions and as we begin to look at public health broadly, what are we doing and how are we, using resources? So this gives us not only a population-based tool, but in addition, going back to the earlier maps that you showed about how do we look at what is happening in a given area or in a given building, that, in infection prevention, we're looking at how do we understand outbreaks, or how do we understand the presence of infection? All of us have, done an outbreak investigation, and we just automatically do a line listing, and we always include, where is that patient, what unit or whatever. But I'm not sure that we ever go any further than that. But I think what you're introducing to us are the fact that there are these tools that we may begin to learn more about that may help us understand disease transmission within our setting and how we need to approach that from an infection prevention perspective, and then what actions might that be able to prompt. So I think these are great tools for us in beginning to learn. Now, we don't know what the future will bring with, new programs and new technologies, but this kind of helps us think differently with the ability to map. So, great. Dr. Mears, I know you always have questions and comments.
Oh, let me see if you have any participants. Do we have anything on the chat?
I see from the chat. It would be interesting if people will put in the chat if you have ever used some type of mapping approach with an outbreak investigation. What did you do? How did you do that? What did you learn? I think that would be interesting as well.
Stephen, the idea of let's say that someone wants to start getting into the topic of geospatial epidemiology, and so many other things that have to do with statistics. What are the resources that we have for someone in an institution or someone that have some ideas? If I want to do this, if I want to move into this, or if I'm a person working in a hospital and I have some patient that are admitted to the hospital with some disease and I'm concerned and I'm trying to develop some mapping, I mean, where should I go to ask for some form of support?
So that's a great question. Ideally, your institution will have some expertise in statistics or data analysis and informatics to be able to visualize that. But on the base level, I mean, you could do what John Snow did. You could take a map of your facility and you could just plot out if you're concerned about an outbreak, you could just map out where patients are being where infections are happening if they're hospital associated infections. And then you could speak with either the building engineers or whatnot to then say, and this was something that happened with SARS in Toronto Hospital, is that they ended up working with their engineers to look at like the airflow diagrams for their ventilation to see if that's what was like one wing essentially was seeing more sort of nosocomial infections. So that could be one resource. Another resource is just if you are interested in doing more community and population-based research with this, so ArcGIS is a program that you can use. There are other programs that can be used to make maps. So that's what the software that I use. And in this presentation, I put a link for the shape files that you can get from the US Census. So they have all sorts of geographic areas and shape files that you can do. There is also a data.census.gov is where you can get lots of demographic information. You could contact the health department if you're looking at disease-specific information, and they may or may not be able to give it to you in the geographic interest of, or if it's too small of an area, they won't be necessarily like stable estimates, but you could look like by county or by state for various trends in disease incidence, or there's various surveys that come out. There's also the Louisville and Jefferson County Information Consortium. So they have a lot of resources specifically for using maps of Louisville. So they have the most up-to-date street and network maps. So if you're interested in doing like a network analysis, or seeing potentially, like if you wanted to try, and one of the utilities of this is you could say, how long does it take for a patient to come to our hospital? You could actually, using their network maps, like find out with a pretty close estimate based on traffic light stops and the road distance traveled. You could find kind of the minimum time it would take for someone to get to a hospital. So there's lots of various tools and information available. So but the first question that you have to do is you just have to, kind of take a look at your organization and see what resources you have available. So
you mentioned that if we want to do research, then we need to be aware of these new technologies. But let's say that as you mentioned multiple times, not COVID. But let's say that no, I'm interested. All of a sudden, I have 20 patients that get admitted to the hospital with COVID on a ventilator, and I noticed that something is unusual, and this may be a new variant. I'm just making up a case, and then you say, okay, where are these people located in the community? And then I want to see in what part of town I need to go and investigate to have a new variant. But then you have the address of the patient. How do you and then I can see that you have, because the address is almost like personal information, and you're going to give me a map with a dot of the address of the patient. Then how do you resolve this with the IRB and the confidentiality?
So there's various ways that you could do that. So the kernel density heat map is a good way if you have enough sort of like addresses where you can aggregate the data in such a way that it's difficult to identify any specific person. Now, a lot of you can use, if you were to translate that address into like a XY, like Cartesian coordinates, most places will do some level of offsetting, so that way you can't directly identify a patient's address. Now, still, depending on the IRB, they may or may not be okay with that. So that's really a question for the IRB, but you can show aggregate data either via a kernel density heat map or a Choropleth map, or there's also dot density maps, which I haven't shown, but they're very similar to a Choropleth map where you have just dots show up per geographic feature. And so then one dot may correspond to, up to 5 cases or something like that. So if you have 50 dots inside this block, then you know that you have potentially 250 cases that happened there. So there are ways that you can aggregate the data so that way it's not personally identifiable. which I think most IRBs will be pretty agreeable to for showing. Now, for things that are rare of incidents, you may still have to suppress that data just because it may still be potentially identifiable. So they may establish a cutoff or something for if there's less than 2 cases in this sort of census tract. So you do need to be careful for internal use, like for disease and outbreak investigations. Obviously, that you may still want to discuss with your IRB, but if you are keeping something entirely internal to your organization and not sharing it, there may be more leeway for the more specific information of that nature. And also, a lot of times the health department is usually on the leading edge of like the contact tracing and that level of intervention for if there's a new outbreak. So you could also talk to the health department and collaborate with them because you may be the person who is sounding the alarm saying, hey, it looks like there might be something happening. So that's there's always collaboration to some extent, especially for the community level of outbreak investigation, just because you have to rely on the expertise of lots of different fields.
I think, Stephen, this is important and why we have public health reporting law, why we have statute that says when you identify a patient with this particular organism or health condition, by law, you have to report. And that report includes, identifiable information. And the health department public health does use that for, these purposes, is looking at, across a community. If we look at what happened with hepatitis A and understanding where those outbreaks were occurring, and even the HIV epidemic, a more recent surge in cases, that, our responsibility to report and, everyone working in infection prevention, we all hate that. It's, it's a lot of paperwork, but this is important for our community to share that information.
And an important consideration there is that for a novel or new disease that you're seeing, it may not be something that is reportable in terms of the mandatory reporting by law. So that may be something still where that's a more gray area, but definitely, obviously, working with the health department in those cases is still, you can utilize their level of mobilization and the specialty to further follow up with that. So. All right, do we have any other questions?
Don't see any, and I did put information about, as you were ending, about next week's Grand Round session will be led by Dr. Matt Song, one of our clinical pharmacists, and I believe Dr. Song will be talking about pharmacokinetics and pharmacodynamics. And you can find this recording. We'll put it up on the YouTube channel, so you can go back and look at some of those maps and continue to learn more. I think, Dave, thank you for putting the training center website up to keep up with what is going on. Boot camp will be October 4, 5, and 6. Then we have the clinical research course that will be, as Dr. Ramirez mentioned, at the Brown Hotel in downtown Louisville. This is going to be an important event as we think about how do we use this information we learn about clinical research so we can understand how to read the literature as we continue our quest in developing that area of expertise. If you're interested in this clinical research course, we'll have a CE for physicians, nurses, pharmacists, physician assistants. So we welcome any of you that like to join us via Zoom. If you are outside of the Louisville area or in Louisville area and want to join via Zoom, I think we still have just a very few spots left for in-person, but I think there's still some available. Right, Dave? I think we have a few. Right. All right. Any closing remarks, Dr. Ramirez?
No, again, it was an excellent presentation. Thank you, Stephen, and thank you all of you for attending this grand round. We keep in contact. Thank you.